I was able to present new data that impact patient care, specifically the patients who receive preoperative or neoadjuvant therapy, who are then found not to have a complete elimination of the tumor after neoadjuvant therapy. So these are patients who do not achieve a pathological complete response. This is very important because new data demonstrate that we can use the pathological result to make a decision related to optimal adjuvant treatment. So I talked about patients who are diagnosed with HER2-positive disease, and the new standard of care for those patients is a drug that is an antibody drug conjugate called T-DM1. And then I also spoke about patients with triple-negative breast cancer. And in that case, although there's some improvements by using a drug called capecitabine, there's much more work to be done. So in the setting of triple-negative breast cancer, I was able to present some rationale for a trial that we're conducting at Mayo Clinic, evaluating a new vaccine approach against the alpha-folate receptor in patients with triple-negative breast cancer. One of the areas that has generated a lot of interest over the last few years has been to actually engage the immune system so the immune system can help fight cancers. And one of the ways to do that is by using vaccines. So vaccines can be developed based on proteins or abnormal DNA or RNA in the tumor. So the vaccine that we're testing at Mayo Clinic is derived against a protein that tends to be overexpressed in patients with triple-negative breast cancer, and that's the alpha-folate receptor. We already know that the alpha-folate receptor appears to be correlated not only with triple-negative breast cancer, but correlated with patient outcomes. So that makes this protein a great target for development of a vaccine. So what we do is that the patients receive the standard chemotherapy as neoadjuvant or adjuvant, and then, because they still have a high risk of relapse, we randomize them to receive a vaccine plus a boost or a stimulant to the immune system called GM-CSF or GM-CSF alone. So we'll see what the data show, but we're very, very enthusiastic about following this research path for patients with triple-negative breast cancer. It depends on the subtype of breast cancer. For triple-negative breast cancer, it's really a clinical trial. Although if a clinical trial is not available, then capecitabine can be considered. For patients with HER2-positive breast cancer, T-DM1 is a very good approach. We still need trials, though, to determine whether other strategies may also be helpful, such as combination trastuzumab-pertuzumab, or the combination of T-DM1 with one of the novel tyrosine kinase inhibitors, such as lapatinib or tucatinib. A lot of progress is being made. At the same time, cancer is still too common, and we need to continue working together to find solutions for our patients.